Good evening, dear colleagues. Welcome to the Gulf Association of Endocrinology and Diabetes webinar. Tonight's webinar is going to be on dyslipidemia and cardiovascular risk management. It gives us a great pleasure to welcome you all this evening. I'm Dr. Nasreen Alsayed, consultant endocrinologist and lipidologist at Kingdom of Bahrain and the past president of the Gulf Association of Endocrinology and Diabetes. As an association, we are very much interested to deliver high quality information in the medical field pertaining to endocrinology and diabetes. Tonight is a special emphasis on dyslipidemia and lipid disorders. It gives me a great pleasure tonight to chair this session. And it gives me a great pleasure to have my dear colleague, Professor Julian Halcox, joining me tonight in giving a talk under this interesting lipid webinar. So just to go over tonight's agenda, we're going to start shortly after this introduction. I'll give you a talk on alarming epidemiological figures on dyslipidemia in the Middle East, so a little bit of some statistical data in the region, then followed by Professor Julian Halcox's talk. He's going to be talking about optimizing cardiovascular risk management strategies to improve non-HDL goal attainment. Professor Julian Halcox is a professor of cardiology at Swansea University Medical School and honorary consultant cardiologist. He's a clinician scientist with a special interest in vascular biology and cardiovascular disease prevention. He's a consultant cardiologist in Swansea Bay University Health Board with an academic base in Swansea University Medical School. He's a graduate of the University of Cambridge, and he was trained in cardiology in London and worked at the University College London hospitals, spending 3 years as a visiting scientist, also at the US National Heart, Lung, and Blood Institute. His research program addresses the understanding and prevention of cardiovascular disease using a wide range of clinical research methods, including non-invasive vascular imaging, biomarkers, clinical trials, and real-world population healthcare datasets. He lectures regularly in a wide range of settings on topics related to vascular biology, risk assessment, and prevention of cardiovascular disease. He's a member of many specialist associations and has held a number of national and international leadership roles. He is currently academic lead for the Welsh Cardiovascular Society and a member of the Caution Heart Group editorial board, and also member of the Medical Sciences and Review Committee for Heart UK, scientific director and committee member of the charity Heart Research Wales. And with that, it's really great pleasure to have Professor Halcox with us. And to start with, we're going to go ahead with the first part of tonight's webinar. Just to let you know, please post your questions under the Q&A box. So to avoid the confusion, please do not post your questions under the chat box, and we prefer to look at them under the Q&A. And with that, I would like to start the first part of tonight's talk. So let's go ahead. Okay, so it's very important when you, we just had a brief sort of overview of the attendees. It seems most of the attendees are general practitioners, primary care, and we have endocrinologists with us, internists, cardiologists. It would be great to share with you some epidemiological figures on dyslipidemia in the Middle East region. And I think that's very, very important because it can definitely have a great impact on your practice and the way that you look at or treat dyslipidemic patients in this region. So to start with, looking at different plasma lipid disorders in the Middle East, it actually runs at a high prevalence rate. Initially, we had very limited data on the statistics and statistical data in the region. For example, a literature review assessing the prevalence of plasma lipid disorders in the Gulf countries using studies published from the 80s to the 2010 found really variable rates range from 3% to 52% across varying population types. Similarly, another study of hypercholesterolemia in the Gulf region evaluated data from early 90s to 2014, found the prevalence range again somewhere between 17 to 55% in males and 9 to 54% in females. So really a wide range of prevalence range. And another study looking at the Africa Middle East cardiovascular epidemiological ACE study, they found that 70% of stable outpatients who attended general practice clinics had disorders of plasma lipids in all countries in the study. And of those, only 16% of subjects were receiving lipid-lowering medications, and many subjects were not achieving the LDL goals and targets. And looking at the cardiovascular disease in relation to dyslipidemia, and as we know that dyslipidemia, one of the major contributing factors for premature cardiovascular disease, it was found that in the region, about 45% of all mortalities were really attributed to cardiovascular disease in the Middle East region, and dyslipidemia is being one of them. And if we look at the different spectrum of lipid disorders in the region, we can see that metabolic syndrome or metabolic dyslipidemia quite to be very prevalent, that we see in metabolic syndrome and diabetes, familial hypercholesterolemia, also, and other genetic forms of lipid disorders tend to be common in the region because of the high consanguinity rate. Now, in the Gulf Race and Inter-Heart study, if you have a close look at this study, it was found that the first presentation of acute MI in this population is actually 10 to 12 years earlier than their Western counterparts. And also, they have found that there is a high prevalence of atherogenic dyslipidemia, which is a metabolic dyslipidemia characterized by high triglyceride level, low HDL, and high LDL cholesterol. And in terms of familial hypercholesterolemia in the region, the conclusion of the study was that it is underdiagnosed and also undertreated in the Gulf region. And it's considered one of the most common genetic causes of premature coronary artery disease in this region. Another study, which was the CIFIS study, and we had the CIFIS International and the CIFIS study of the Arabian Gulf region, and this study evaluated treatment efficacy of dyslipidemia in a population of more than 5,000 subjects from 6 Arab Gulf countries, and they assessed patients who were at high or highest cardiovascular risk according to the guidelines at that time. So this is like looking at the 2016 guidelines. So the highest risk group, these are patients with established cardiovascular disease. They have found that the LDL target was achieved only in 25% of patients, and the non-HDL target achieved only in 36% of patients, and the ApoB targets in 38% of patients. While in the high-risk group patients, 46% achieved the LDL target, 58% the non-HDL, and 51% achieved the ApoB targets. And when we look at a sub-study of the CIFIS Gulf study looking at the sex disparity and sort of different the gender differences in terms of the attaining lipoprotein goals. So looking at this slide, as you can see here, the very high risk patients, and these are patients with established cardiovascular disease. So looking at the blue bars representing females, the red bars representing males, you can see that unfortunately males were doing better in terms of attaining the LDL and the non-HDL goals in this very high risk group. But still, I mean, the percentage-wise is still considered low. So looking at only 30% of patients were attaining the LDL target in the very high risk category, compared to 21% only in females. Similarly, across different lipoprotein groups. And when we look at the high risk, and these are patients who don't have really established cardiovascular disease, but they are considered high risk based on history of diabetes, based on history of FH, CKD. You can see that in these group of patients, more or less the distribution is sort of even between males and females in attaining the lipid targets, and a little bit better than the very high risk group, with 60% achieving almost the non-HDL target and only 48% achieving the LDL target in this population. Another study, which was the DICE study, the Dyslipidemia International Study of the Middle East, they also looked at a large group of population looking at the different lipid disorders and the different sort of lipid-lowering agents that were used. So looking in terms of the statins being the most commonly used, of course, and according to the guidelines. So looking at these high risk, very high risk group, these are the red bars, and the non-very high risk, the blue bars. And then potency down here is the potency of the statins used and detected in this registry or study. So one being like equivalent to simvastatin 5 milligram, 2 being 10 milligram simvastatin, 3 being 20 milligram simvastatin, and 4 being 40 milligram, and 5 being 80 milligram, and 6 being more than 80 milligram simvastatin. So you can see in the very high risk, the red bar, most of the patients were receiving actually a moderate sort of intensity statin, and 32% only were receiving the high intensity statin. And when we look at the very high or the non-very high risk, about 50% were receiving the moderate intensity statin. And overall, you can see that between the very high and the high risk group, the majority of patients were on moderate intensity statin. Now, as we said earlier, the common lipid disorders, according to all these literature reviews, is found to be genetic, the hereditary forms, especially the familial hypercholesterolemia. We have other genetic forms like the familial combined dyslipidemia, and these disorders, patients have high LDL as well as high triglyceride levels. And also we have the metabolic dyslipidemia, which is the typical lipid disorder that you see in patients with metabolic syndrome and diabetes. So having a quick glance at the familial hypercholesterolemia, which is one of the most common genetic disorders here in the region. So FH actually confers a greatly increased risk of atherosclerotic cardiovascular disease. It is characterized by high LDL levels. If untreated, FH results in premature atherosclerotic cardiovascular disease and premature death. And FH is transmitted as an autosomal dominant manner and can be either heterozygous or homozygous, homozygous being the more severe form. FH is unfortunately underdiagnosed in the Middle East. Both heterozygous and homozygous FH are important in the Middle East due to high level of consanguineous marriages. So if you look at the consanguinity rate and marriages in the different Gulf countries, as you can see, that's a very high percentage, as you can see. So it ranges between 40 to 50%, reaching to as high as almost 60% in countries like Saudi Arabia. So you would expect how this disorder tends to be prevalent. So not until recently, we didn't know much about it until the recent registry established that I'm going to show you very shortly. So FH is transmitted as heterozygous, which is the prevalence, worldwide prevalence is 1 in 250, and homozygous, the worldwide prevalence is 1 in 300,000. And usually the diagnosis is using assessment of LDL cholesterol levels. Most of the time, the LDL is it's from 5 and above range, so 5 millimoles or 200 milligrams per deciliter and above, you should suspect FH. Patient could have xanthomas, family history of lipid disorders, or premature cardiovascular disease. And also, you could use different sort of criteria to diagnose FH patients. You could use the WHO criteria, the Dutch Lipid Network criteria, the Simon-Broom criteria. And of course, the physical examination, these patients might have tendon xanthomas or xanthelasmas detected on clinical examination. And surprisingly, looking at FH and different genetic mutations, as far as this study is concerned, which was back in 2015, there were about 57 mutations detected in the Middle East and North Africa relating to the FH. So as you can see, we have a mutation detected in Bahrain related to LDL receptor, many mutations in Lebanon. You can see many mutations detected in Saudi Arabia, mostly related to the LDL receptor mutations. And we know there are other mutations related to the PCSK9 gene, to the ApoB gene as well, but mostly in this region is there are unique genetic mutations that were detected unique to this region and not really discovered in other parts of the world. And taking a look at a glance at the world, what's happening in terms of the heterozygous FH, you can see it's more prevalent than homozygous. Countries like United States, UK is like 1 in 623, and United States 1 in 250. But you can see that certain countries like Lebanon, it's like 1 in 85, while the homozygous, it's 1 in 300,000 or more. So this brought us to the looking at all these epidemiological data, actually brought us to an idea to come up with this project, which was the familial hypercholesterolemia, the Gulf familial hypercholesterolemia registry. That was, I had an honor to work with this esteemed group of colleagues in the Gulf region, establishing this registry. And actually our first meeting was back in 2015 when we established the basis for this registry. So what we did was that the aim was to really detect the prevalence and the genetic characteristics of FH in the region. So we recruited adult patients age 18 to 70 years from 9 hospitals in the 5 Arabian Gulf countries. And we screened a total database of more than 34,000 patients in the out-clinic settings. So we had categorized the study into category 1, suspected FH from screening the medical records or patients attending the clinics. This was phase 1. And then phase 2, we took these patients that we have collected and from the previous clinical diagnosis of FH, and we categorized them into definitive, probable, or possible based on the Dutch Lipid Clinic Network criteria. Then only the definitive and probable FH patients move to the phase 3. And this is what we are doing right now. We're doing the genetic testing on this pool. And then finally, those with the genetic evidence of mutations, along with previously detected genetic mutated FH patients, will be moved to the phase 4, where we will follow these patients, see their cardiovascular outcome, their responses to different lipid-lowering therapies. So the preliminary data of phase 1, from looking at a quick glance at the prevalence of the disorder in the region, we found that from the final cohort of more than 3,000 patients, we found that the definitive FH is actually 203. So overall, the prevalence for probable and definitive FH is 1 in 232. So this is a quite prevalent genetic disorder in the region that we didn't know about, and we thought that the prevalence might be higher, like 1 in 500 or more, but it turned out to be 1 in 232. And another study, subsequent publication that we had, we published the results of this FH registry, which is phase 2. And as you can see that these are the patients that we had, a likely FH, a possible FH, and we had the probable and definitive FH together. And you can see that these patients, like for example, tendon xanthomas, mostly were seen in patients with probable or definitive. You could not detect the tendon xanthomas in the possible FH. And premature coronary artery disease in 33% of patients with probable and definitive. And you can see here the gender distribution, also 43% were female. And when we look at the different statins that we used in these registry, you can see that the blue bars are low intensity statin, orange bars medium, and the green is high intensity statin. So among the possible patients, possible FH patients, most of the patients were receiving the medium intensity statin, and in the category of probable and definitive, most of the patients were receiving a high intensity statin. So at least that's a good sort of percentage, but still we had like 23% receiving medium intensity statin and 15% receiving low intensity statin. And when we look at the different lipid lowering therapies used in the registry, you would see most of these patients were using atorvastatin and rosuvastatin. And looking at the other lipid lowering therapies like add-ons, barely were used, like ezetimibe, just like 33%, fenofibrate, very few, 1.4, the omega-3, very few, 0.7, PCSK9 inhibitors were used only in 1.4% in our registry, and 2.8% had LDL apheresis. And very important, looking how many of our patients in this registry achieved the target. So the top is the 2016 European guidelines, and the lower is the 2019 European guidelines. So the blue bars representing the high risk, the red bars, the very high risk. You can see that, unfortunately, only 12% of the high risk were achieving the LDL targets according to 2016 guidelines, and 30% achieving the non-HDL target, while only 3% in the very high risk group were achieving the target LDL cholesterol, and the non-HDL 6%. But look at when we implement the 2019 European guideline, you can see only in the very high risk group, only 1.1% achieving the non-HDL target, and only 0.4% achieving the LDL target. I mean, these are very disappointing, really, data to see how badly our patients are doing, as we have seen in the registry. Now, our data were also sort of incorporated into the more sort of global registry by the EAS, familial hypercholesterolemia. They had their data published recently, and the data of the Gulf was also incorporated. Our data was incorporated with their data. So the global registry included 42,000 adults. And we had, of these, we had 75% were diagnosed according to the Dutch Lipid Network, and 84% according to the WHO region. The median age of entry of participants were 46 years, and the median age at diagnosis of FH was actually very late, like 44 years, with 40% of participants younger than 40 years when diagnosed. And the prevalence of coronary artery disease was 17.4%. And among patients receiving lipid-lowering medications, 81% were receiving statins, same to what we have found in our registry. And among patients receiving lipid-lowering medications, only 21% were on combination therapy. Only 21%. And the median cholesterol was 5.4 among patients not taking any lipid-lowering therapy, and 4.2 among those taking lipid-lowering therapy. So that's really disappointing also level of LDL cholesterol. Among patients taking lipid-lowering medications, 2.7% had LDL cholesterol lower than 1.8. So only 2.7% had sort of a target below 1.8. So this was like a brief overview on FH in the region and how the data were incorporated along with the global registry, and how the overall data pretty much similar to what's going on globally, it's happening in the region. Probably we are doing even worse in terms of attaining our goals. Now, the second most common prevalent lipid disorder is the metabolic dyslipidemia. Metabolic dyslipidemia is actually even more prevalent than FH because of the high prevalence rate of diabetes in the region, about 30% diabetes rate, and more of that with metabolic syndrome. So we know, most of you know, that the characteristic features of metabolic syndrome or the metabolic dyslipidemia is in relation to type 2 diabetes, which is very prevalent in this region, as we said, and the Gulf countries are among the top listed countries globally in terms of the high prevalence rate of diabetes. So as you can see, that the characteristic findings that you see, that high triglycerides in metabolic dyslipidemia, you could have normal or high LDL cholesterol, and mostly these are small, dense LDL cholesterol particles, and you have low HDL cholesterol, marking the metabolic dyslipidemia. Very, very important in metabolic dyslipidemia or diabetic dyslipidemia is non-HDL. You have to look at the non-HDL in these patients because it will give you a more sort of a background on what's going on with these patients more than the LDL. As you can see, the non-HDL is capturing all the ApoB containing lipoprotein particles, starting from the chylomicrons, the VLDL, the intermediate density lipoproteins, the Lp(a), as well as the LDL cholesterol. Now, with that, we came up with a sort of consensus recommendation for managing lipid disorders in the Middle East. This sort of guideline we published back in 2016. A new version of this guideline will be published very soon, hopefully by end of this year. I had the great pleasure to work with my colleagues, as you can see the names here in the Gulf region, to publish this recommendation, and I can assure you the new recommendations will be very much in line with the global recommendation from the European and the American guidelines. So what we did in this recommendation is that we looked at the screening. We set sort of criteria who to screen. So we recommend that you screen all adult patients starting age 20, actually. And why did we do that? Because in the region, high prevalence, as we said, of the FH now, it's very important to detect these patients. Unfortunately, according to the registries, we are detecting them very late while they are in their 40s or presenting with heart attack. So you need to start looking at these as early as possible. So screening could start at age 20. You should screen, of course, all diabetic patients, hypertensive patients, patients who come with their first evidence of atherosclerotic cardiovascular disease, patients with obesity, a chronic inflammatory autoimmune disease, CKD, family history of atherosclerotic cardiovascular disease, and offspring of patients with FH disorder. And this is what I do in my clinic. As soon as I diagnose someone with FH, I do a cascade screening. So I screen the family member, the siblings, and I go downwards and screen the children as well. So in our recommendations and guidelines, we definitely emphasize on looking at the LDL, but we give a great emphasis also at looking at non-HDL. And we treat the non-HDL as equally important as LDL because of the high prevalence of metabolic dyslipidemia in the region. And non-HDL is very simple. And most of the physicians, they miss looking at it. Unfortunately, because most of the labs, when they give you or they print the sort of the results or you view the results, they just give you the LDL and the HDL. So the non-HDL is very simple, and you can just calculate it by subtracting the HDL from the total cholesterol level, and you get your non-HDL cholesterol. Lp(a), it's not commonly used because of the variability in the assays. So we need sort of standardization due to sensitivity issues with the assays in detecting properly the Lp(a). But in really reputable labs where you have you can assure you can get a high quality Lp(a) result, you could do that. Now, the targets that we set back in 2016, we said that for the high-risk patients, these are patients with evidence of atherosclerotic cardiovascular disease. We looked at percent reduction, 50%, and we said the target should be for LDL below 1.8 or below 70. But this is going to be changed, and being the primary author of the new recommendations, I can tell you that we're going down with that. So we're going to have a different sort of categorization of risk categories. It would be very interesting to look at that, but we're going to go with a European lower than that, which is below like 55 milligram per deciliter or 1.4. And for the moderate risk patients, a 30% reduction and going down below 100 milligram. We set a target for the non-HDL in these patients, always 30 milligram higher than the LDL target. We also looked at given a great emphasis on HDL and triglyceride, and we recommend that treatment should be recommended when you have a triglyceride 200 and above. You should definitely consider, after lifestyle modification, adding triglyceride lowering agents to statins. We also emphasize on genetic testing in our recommendations. If you suspect FH, then genetic testing should be really considered if available and affordable by the patient. And in terms of risk assessment in our recommendations, as you can see, there are different risk sort of calculators available, but in our recommendation back in 2016, we thought that the Framingham risk factor sort of suits our region more, given taking into consideration different ethnic backgrounds and the Framingham risk score. We might see a different sort of recommendation in our newly updated recommendation, which will be published soon. Now, looking at our sort of recommendation for lipid-lowering agent for this region, for the Middle East region, of course, we're going to go ahead with statins as the first choice. And our first choice with statin, as you can see, is whether your patient has metabolic dyslipidemia, type 2 diabetes, or FH. Statins should be your first choice, followed by ezetimibe, again, across the different sort of the disorders here, and then followed by fibrates. So fibrates are sort of a third recommendation here at the 2016 guidelines, but also we recommended PCSK9 inhibitor. Now, maybe the place of the PCSK9 inhibitor based on the evidence is moved now to the third option in our newly hopefully published guidelines very soon, but very important to look at this category of fibrates. Now, even though the guidelines recommend PCSK9 inhibitors after statins and ezetimibe, but sometimes PCSK9 inhibitors are not available, or the cost might be an issue, or the availability might be an issue. Some patients sometimes start the therapy and then discontinue due to unavailability or again cost reasons. So we just want you to know you should not stop there, right there at just statin and ezetimibe. You have the option of adding fibrates, and especially with metabolic syndrome and diabetes, it works very well because fibrates will lower your LDL and lower your triglyceride level. But we see in the region a lot of physicians, they hesitate thinking that adding fibrates, and we're looking at especially fibric acids, not like gemfibrozil. Gemfibrozil would have some interactions with the statins, but we are looking at fenofibrate, especially fibric acid derivatives. These are the agents that have found to be pretty safe when you combine them with statin therapy. So no worries if you're stuck there, you don't have a PCSK9 inhibitor available, and you just have your patient on statin and ezetimibe, your patient still not attaining the target, you can go ahead with fibrates. So this study actually showed, and most of the clinical studies showed that if you combine with gemfibrozil, maybe you would see some reported side effects with statin. But look at when you combine it with fenofibrate, 15 times lower in combination with statin therapy. And also, it was found that fenofibric acid and fenofibrate do not inhibit the CYP3A or CYP2, a different cytochrome. So there is no significant effects on oxidation, glucuronidation, or plasma concentration of statins. And I do that in my clinical practice. If I need to, I do combine with statins. And when statin fibrate combination therapy is indicated, fenofibrate or fenofibric acid is of course preferred over gemfibrozil, as I showed you from the data previously. So in conclusion, plasma, this was a sort of a brief sort of pure epidemiological sort of review on the lipid disorders in the Gulf region. And it is actually estimated to be quite prevalent, ranging almost 50% and in some countries 60% prevalence rate. Metabolic and diabetic dyslipidemia and familial hypercholesterolemia are among the most prevalent lipid disorders in the region. FH tends to be underdiagnosed and undertreated in the region. Prevalence of FH was found to be 1 in 232 per our data from the Gulf FH registry, and hope we can have in the future registry looking at all sort of dyslipidemias in the region, like the metabolic and the combined and different sort of dyslipidemias in the region. Median age at diagnosis of familial hypercholesterolemia was 44.4 years. Among general lipid disorders in the region, LDL levels were found not at target in a very high population, 72 to 80% of the patients, they are not at their target, unfortunately. Among FH patients, more than 90% have LDL above 1.8. Statins are the most used lipid-lowering agents, while combination therapy is used in less than a third of patients. So this is less than a third, 21%. And that is very disappointing, seeing that we are not attaining the targets and we are not using really the combination therapies like ezetimibe, PCSK9 inhibitors, and fibrates. So the main challenges for underdiagnosis and not attaining targets, what could be these main challenges? And this is what we were sort of brainstorming with our colleagues in different meetings. So maybe there are limited lipid-lowering therapy options in primary care setting in some countries. So for those of you primary care physicians, maybe you don't have access to ezetimibe, to PCSK9 inhibitors, or to fibrates to add to your statin therapy, or lack of specialized lipid clinics and preventive cardiology clinics, maybe conflicting approaches in lipid management. You are confused with the guidelines. Some guidelines recommend percent reduction. Others look at targets. There are many guidelines, but I was trying to reassure you that we have sort of recommendation and guidelines for this region that has been published, and we have a new version coming up. So to access these guidelines, you can access it through our association at the Gulf Association of Endocrinology and Diabetes, GAED.info, and you can see a list of published guidelines in the regions pertaining to different endocrinological disorders. One of them is the dyslipidemia. Patient-physician concerns of side effects from high dose or combination lipid-lowering therapies, drug interactions. Believe me, the concerns are not only from the patients, but also from physicians. Polypharmacy, those of you in primary care, you can see your patient in the clinic, you're dealing with diabetes, thyroid, hypertension, you name it, so many things. And unfortunately, the lipid disorder and the targets of the lipoproteins are not really, are overlooked and not really properly addressed. Lack of reference systems for high-risk patients and complex lipid cases, and busy practices, patients with several comorbidities, as I mentioned. And with that, I would like to conclude. Thank you very much for your attention. And we're gonna leave the questions for this part of our webinar tonight at the end, when we have our panel discussion with Professor Julian Halcox. And now I would give the platform. I introduced Professor Julian Halcox already, so for those of you who are joining us late, Professor Halcox is a cardiologist and is going to give us a talk on non-HDL, on optimizing cardiovascular risk management strategies to improve non-HDL goal attainment. Professor Halcox, the platform is yours.
Thank you very much. What a wonderful presentation. It's made my job a whole lot easier. So my title is Optimizing Cardiovascular Risk Management, and I've caveated this to emphasize the fact that I'm going to be speaking about the high-risk patients and strategies to improve non-HDL goal attainment. But the brief that I was given when invited to give this lecture was incorporating highly purified omega-3 ethyl esters into the management. And I think to do this, we need to think beyond just cholesterol levels, total cholesterol levels, LDL cholesterol levels, and non-HDL cholesterol levels purely in their measurement, but to think a little bit more broadly about lipid biology and the role of lipids in atherosclerosis and cardiovascular risk. And whilst I think non-HDL cholesterol targets are very, very important, I do think we have to look more widely, and I hope to make the case for why as my talk goes on. This is my set of disclosures. I've received some honoraria for speaking, consulting for a range of companies that are involved in cardiovascular risk management and in the field of lipids. And I'm just going to focus to start with, and we've heard a little bit about this already, but just to describe how lipids are absorbed and formed in the gut in a very top line way. So lipids are clearly absorbed in the diet and taken up from the gut in the form of chylomicrons, the ApoB48 containing lipoproteins, and during their transit there'll be some lipid will be absorbed from them through the capillaries, but the majority of the chylomicrons are taken up directly through the portal circulation by the liver, where most of the processing of lipids takes place. And from there, VLDL is secreted from the liver. Again, this is ApoB100 containing lipoproteins. passes out into the circulation. Lipoprotein lipase will act on the VLDL, releasing free fatty acids, and that will result in the formation of low density lipoproteins via VLDL remnants, and from which cholesterol can be taken up into extrahepatic tissues and also returned to the liver for reprocessing. Of course, HDL is the ApoB containing lipoprotein that's involved in reverse cholesterol transport, but also has another, well, a slew of other properties such as anti-inflammatory, antioxidant properties, and is involved in sort of a number of anti-atherosclerotic processes, and hence the term good cholesterol. So that's a sort of a quick top line overview of the way lipids are absorbed, processed, and handled within the system. Yeah, so if we think about hypertriglyceridemia and the metabolic dyslipidemia, the most common causes for this are obesity, particularly visceral obesity in association with insulin resistance, type 2 diabetes, and the metabolic syndrome, typically driven by calorie excess, but particularly carbohydrate excess, where the excess carbohydrates, which you can only store so much glycogen, so the excess carbohydrates are converted into triglyceride and stored in fat, and that's associated with the high triglyceride levels, and they're not free triglycerides. These are carried around in the triglyceride-rich lipoprotein, so the VLDL cholesterol particles, and this is associated with a range of abnormalities, which I'll describe later. But if you find someone with that elevated triglycerides, clearly the calorie imbalance, insulin resistance, metabolic syndrome is the cause of the majority of patients with the hypertriglyceridemia, metabolic dyslipidemia. But we also need to think of other important causes such as thyroid dysfunction, liver disease, renal disease, the most common sort of really polygenetic driver of the familial combined hyperlipidemia, and other genetic abnormalities. So as Nasreen has mentioned earlier, we need to think about the role of lipids in the pathogenesis of atherosclerosis and their contribution to atherosclerotic risk. And if we think of the range of the lipoproteins in the blood, because it's really, we need to think about lipoproteins because these are the building blocks of the atherosclerotic pathways. There's the ApoA particles, the HDL, and the ApoB particles, the LDL, the IDL, the VLDL, and chylomicrons and chylomicron remnants. But when we're thinking about atherogenic lipoproteins, in particularly in regard to the atherosclerotic risk and thinking about the lipids that we need to be targeting for risk management, it's these ApoB 100 containing lipoproteins, the LDL, the IDL, and the VLDL, which we need to be focusing on. And these are the lipoproteins in which the vast majority of the non-ApoA associated cholesterol is carried around, so hence the non-HDL cholesterol. And it's these lipoproteins which are the priority target for cardiovascular disease prevention. And these are part of all the major international guidelines, and of course your local guidance, which Nasreen has summarized very nicely in her preceding presentation. So I just want to say a few words about how these atherogenic lipoproteins contribute to the development of atherosclerosis, which is of course a complex process, a multifactorial process, where in this sort of cartoon of the arterial wall, we can see the pink single cell layer of endothelial cells, and then a virtual subendothelial space just underneath this, and then the media with the smooth muscle. So in the setting where we have the vessel wall exposed to cardiovascular risk factors such as the mechanical stresses of hypertension, the chemical stresses of diabetes, lipoprotein, cigarette toxin, a redox, a sort of oxidative stress environment, and played out in the context of the individual's genetic susceptibility, we see activation of the endothelium with expression of surface molecules such as selectins and adhesion molecules, and we get release of cytokines and chemokines that actually promote inflammatory processes within the vessel wall and also attract white blood cells to the activated endothelium, where they can take part in building the atherosclerotic disease process. Now, the important thing to remember is that although this is an inflammatory disease, it's a particular kind of inflammatory disease of which the hallmark is the transit of lipoproteins into the subintimal space and the uptake of these lipoproteins by the monocyte macrophage lineage cells, which are the building blocks of the atherosclerotic plaque. And the LDL, the ApoB containing lipoprotein, so the LDL, the remnant particles, the smaller VLDL, most non-HDL cholesterol particles, apart from the very largest VLDL and chylomicrons, these can get into the vessel wall. But the more numerous the particles are, the smaller these particles are, and the more chemically modified they are. For example, oxidative modification or glycation on their surface, the more likely they are to stay within the subintimal space longer and become more attractive for the scavenger cells, the macrophages, to take them up, and they'll do that via a scavenger receptor. And the smaller and denser and the more chemically modified these ApoB lipoproteins are, the more atherosclerotic they are. So these patients with the metabolic dyslipidemia are more likely to have this dysfunctional atherogenic lipoproteins, which are more likely to get into the vessel wall and to be taken up by the macrophage monocytic lineage cells and built into plaque. As this process proceeds with the risk factor exposure, the endothelial activation, the lipoprotein transit, the cellular infiltration, and the lipoprotein uptake by these macrophage lineage cells, these plaques in the vessel walls will become more inflammatory, more lipid-rich, and more susceptible to rupture, so the so-called unstable plaque. And when these plaques rupture, they will go on to cause a thrombosis within a vessel, which is the cause of almost all heart attacks and the majority, although obviously not all strokes, but it's the more common cause of stroke as carotid plaque thrombosis and embolization. So this is really, really important. So it's this continuous uptake of lipid, promotion of inflammation, building up of a vulnerable lipid-rich, thin-capped plaque, lipid-rich that's more susceptible to rupture and thrombosis. So what do we do about it? Well, we know a lot about statin therapy, and I'm sure most of you are very familiar. I'm sure you've all given talks on statin therapy and how important this is to reduce cardiovascular risk in people at risk and at risk of cardiovascular events. And these are some data from what is a really landmark paper, the Cholesterol Treatment Trial Collaborators, showing that there's fairly consistent relative risk reduction with statin therapy across all levels of risk in at-risk populations who've been incorporated into these randomized placebo-controlled trials of lipid lowering. So we're seeing a roughly 20 to 25% reduction in relative risk of events per 1 millimole per litre reduction in LDL cholesterol in these clinical trials. And we know that the more intensive statin therapy, the better the outcomes, particularly in the very high risk patients. And so beyond statin therapy, we know from the Improve It trial that ezetimibe has a small but statistically significant reduction in events. But here, this is an example of one of the more recent trials, the Fourier trial, looking at the PCSK9, anti-PCSK9 agent evolocumab, similar results we saw with alirocumab versus placebo in patients with elevated LDL cholesterol and non-HDL cholesterol and other markers of risk, the majority of which had stable cardiovascular disease. And we saw that there's significant reductions, around 60% further reductions in LDL cholesterol. I think in the Fourier trial, they went down from starting LDLs around 2.4 millimoles per deciliter down to LDLs of 0.8 millimoles per deciliter. So really very low achieved LDLs in this trial of patients who weren't at target on optimal maximal tolerated doses of statins. We can see here that the reduction in the combined MACE, cardiovascular death, non-fatal MI, non-fatal stroke was reduced significantly, but predominantly due to reductions in major vascular events, so MI, strokes, coronary revascularizations, no difference in mortality, interestingly, in this subject, but hard cardiovascular events reduced significantly. We saw very similar results from the Odyssey trial of alirocumab, but interestingly, post-hoc analyses suggest that the real major clinical benefits with the PCSK9 therapy were in people who had starting LDL cholesterols of around 100 milligrams per deciliter, roughly 2.5 millimoles per deciliter and higher. So even though we're aiming for lower targets, it doesn't seem to be the case that you get that much incremental benefit from these fairly profound additional reductions in LDL cholesterol, unless your LDL cholesterol is fairly highish, fairly suboptimal to start with. So maybe there's less benefit if you've got an LDL between 1.4 and 2.0 milligrams per deciliter from adding in PCSK9 therapy. This is just a thought, but I think it's important to think about where the real added value is going to come from using these new exciting agents. So I think we know from the studies that if you bring the LDL down very aggressively, and again, imaging data will support this treatment, support this thesis, that you can not necessarily prevent progression of plaque biology, but you can actually, of plaque size, but you can change the composition of the plaque, where you change it from an evolving lipid-rich, thin-capped plaque to a more stable, lipid-depleted, thick-capped plaque, which probably has a similar degree of stenosis, but isn't going to progress anymore and is going to be less susceptible to rupture, and therefore we'll get a reduction in major cardiovascular events, which is extremely reassuring. So the therapeutic options for reducing cholesterol levels, and not by this the ApoB containing, so non-HDL cholesterol levels. So statins, ezetimibe, PCSK9 antibodies. We now in the UK we're licensed to use the small interfering RNA and inclisiran versus PCSK9. Novel therapy, still no outcome data on that yet, although it's achieving similar reductions and sustained reductions in LDL cholesterol with a 6-monthly injection, as we see from fortnightly to monthly injections with the PCSK9 antibody therapy. There's also data showing the potential safety and lipid lowering of bempedoic acid, but again, waiting for major outcome data, and also with bile acid sequestrants, but I think we all know how poorly tolerated these are. But I think what I want to pivot to in the next part of my talk to obviously acknowledge how important it is to use these LDL, non-HDL cholesterol lowering therapies to get the levels down. We really do need to be thinking beyond just the levels of cholesterol and non-HDL cholesterol, and actually thinking fundamentally what's going on with the biology of the lipoproteins, because it's the size and it's the chemical, sort of the surface modifications of these agents, of these lipoproteins, that's really important in driving the atherosclerotic process. So I want to pivot to talking and thinking about beyond the non-HDL cholesterol level and thinking a little bit about the biology of the process, and thinking about ApoB containing lipoprotein atherogenicity. And Nasreen has already alluded to this important triad of atherogenic dyslipidemia that we see in our patients with type 2 diabetes, central obesity, insulin resistance, and the metabolic syndrome. That if we think of the lipid components, although the LDL levels might not be that high, if we actually do an analysis of this, we will see increased levels of ApoB, and that tracks with increased numbers of these lipoproteins per unit per millimole, for example. So for any given concentration, the individuals with this atherogenic dyslipidemia will have more smaller, denser LDL particles. And these are obviously more likely to be chemically modified and more likely to get into the vessel wall and be taken up by macrophages and built into plaque. And the sign for this is elevated triglycerides, low HDL cholesterol in patients with a degree of insulin resistance and typically with abdominal obesity or high levels of visceral fat. And this atherogenic lipid triad and these atherogenic ApoB containing lipoproteins, they're characterized by surface glycation and oxidation, and also in the context of inflammation, all of which drive that atherogenic process. So more likely to be taken up and built into plaque. And we know that if we just look at the epidemiology, that the higher the levels of non-HDL cholesterol, the greater the cardiovascular risk, even when we adjust for other major risk factors, including triglycerides and LV dysfunction and so forth. And these are data I think that are likely to be well known to all of you, data that have been around for a while, extremely important pooling of most of the large major epidemiological cohort studies tracking these lipid variables with outcomes. And non-HDL cholesterol is one of the strongest predictors of clinical outcome of all of the lipid variables. Of course, the inverse relationship between high HDL cholesterol levels and cardiovascular risk. But unfortunately, we've seen that agents targeting raising levels of HDL cholesterol don't seem to improve outcome. And that's perhaps because all we're doing with those agents that have been tested is increasing the amount of the amount of cholesterol that's carried in the HDL fraction, but isn't actually changing the fundamental biology of the HDL or the overall balance of lipid risk, which is largely being driven by the composition, the biology of the non-HDL apolipoproteins, and perhaps the function of the HDL cholesterol, the anti-inflammatory and antioxidant properties, which aren't being improved just by having these particles stuffed with more cholesterol, which, for example, the cholesterol ester transferase proteins were doing, CTP inhibitors. But anyway, this is really to emphasize the importance of non-HDL cholesterol, because these levels are important regardless of predictive, regardless of triglyceride levels. So if we come to see how this epidemiology is really sort of translating in patients, say in clinical trials, I think it's useful to think of outcomes in the Accord lipid trial. Now, this was a group of patients with type 2 diabetes who had, well, this is in all comers, these were high-risk patients with type 2 diabetes. They were all treated with a statin to fairly acceptable levels of LDL at the time, so LDL levels of 2.1, again, maybe not as aggressive as the modern targets, but levels that are not unreasonable on background statin therapy. And we could see that in the individuals whose triglycerides were below 2.3 and whose HDL cholesterol above 0.9, so without the sort of typical metabolic syndrome dyslipidemia triad, their event rate was 10% over the period of the follow-up, which is around 4 years or so. And in contrast, the individuals who had the elevated triglycerides together with the low HDL cholesterol, these individuals' event rate was 17%, so roughly 70% greater relatively greater risk. And this is in the placebo arm. We can see that if you just take patients on background statin therapy, standard dose statin therapy, if they have this metabolic syndrome type lipid profile, low HDL, high trigs, 70% worse cardiovascular outcomes. And that's because this is tracking with the dysfunctional HDL and the pro-atherogenic ApoB lipoproteins, despite reasonable control of your non-HDL cholesterol, LDL cholesterol. So if we look at this in a meta-analysis of clinical outcome trials, we can see if we focus on the individuals whose LDL cholesterol was at the target of that at that time, the 100 milligrams per deciliter, and we look at outcomes here whose non-HDL cholesterol wasn't controlled, we can see that the relative risk was about 1/3 higher. So even if your LDL cholesterol levels are at target, if your non-HDL cholesterol isn't at target, and that really is largely down to the large amounts of triglyceride and high levels of triglyceride-rich lipoproteins that are not in the LDL subfraction, but the IDL and small VLDL and chylomicron remnants, but particularly IDL, smaller VLDL, and associated with the smaller, denser LDL at any given concentration of LDL, we can see that there's a substantially greater relative risk of events. And that I think is fairly instructive, that we need to look beyond LDL target, particularly in the individuals with high triglycerides, low HDL, type 2 diabetes. So we think of it just in terms of the practical relevance, non-HDL, it encapsulates the cholesterol carried in all the ApoB lipoproteins, even lipoprotein a, it correlates very well with ApoB. It's an indirect estimate of the LDL particle number, so the smaller dense, a predictor of smaller, denser particles, and has a better relation to cardiovascular outcomes than LDL cholesterol alone. And particularly in patients with type 2 diabetes and high triglycerides, one would get falsely low LDL cholesterol values when you just do a simple calculation using the Friedwald formula. And it doesn't actually require you to do this sort of mathematical contrivance where the relationship between numbers and biology breaks down at high levels of triglycerides. And it's practically advantageous because it doesn't require you to fast, because the total cholesterol and HDL levels aren't really changed that much of at all shortly after eating. It's obviously easily calculated, and you can use it in patients with high triglyceride levels to get a feel for their cardiovascular risk. And so if we go back, cast our minds back to that slide, the diabetes-treated patients on statin who had low HDL and high triglycerides, these guys with the atherogenic lipid profile are still having events despite statin therapy, okay? So this is an important thing to consider. And if we look at over here on the right, the parallel, if we look at all the patients in the ACCORD study and in the outcomes in the patients who were on placebo in silver and the patients treated with the fenofibrate in blue, we could see if your HDL and triglyceride levels were more acceptable, there wasn't that much difference in the outcomes. However, in these people with the residual atherogenic dyslipidemia, there was a significant improvement in their clinical outcomes when they were treated with fenofibrate. And you could see the fenofibrate treatment got their absolute risk down to almost as low as the individuals who were not on fibrates but had an acceptable HDL and triglyceride profile. So we can see here that there's substantial and meaningful, not only reductions in cardiovascular risk, but almost normalization of the normalization for the risks in a group of high-risk people. So you could bring that down to the risk of statin-treated patients without the residual dyslipidemia. Okay, so that's the fibrates, and Nasreen's already talked about the safety of fenofibrate in combination with the statin, which is why it's really the preferred fibrate to use in our at-risk patients in whom we're using statin therapy as the frontline mainstay of lipid-lowering therapy. But I now want to really pivot to talking about omega-3 fatty acids and what I think we should be thinking about in terms of how we use them and when we use them in our cardiovascular risk patients. So omega-3s are long-chain polyunsaturated fatty acids. They have multiple carbon-carbon double bonds, and the length of the chain and the position of these carbon-carbon double bonds makes them sort of more geometrically complex. The saturated fatty acids are fairly straight and more linear molecules, whereas the omega-3s have a more complex biology, more complex structure. It means that they're soluble, that they're sort of liquid down to much lower temperatures, which is how many of these marine species that live in very cold waters don't actually freeze or solidify when the temperatures that they're in are sort of close to freezing point. So they actually allow membranes to remain fluid, and which is why the oils that are rich in omega-3s are not solid at room temperature, like, for example, butter and other oils which have a greater proportion of saturated fatty acids. But beyond that, they have a number of important biological effects. And I'm not going to go into the biology too much, but I think if we consider the concept of the vulnerable patient, so vulnerable inflamed lipid-rich plaque, vulnerable blood with triglyceride-rich lipoproteins, inflammation, vulnerable myocardium, ischemic, predisposing to arrhythmias. There are a number of preclinical and clinical translational studies that have shown that omega-3 PUFAs can actually interact with multiple biological pathways that potentially can improve cardiovascular outcomes. So unfortunately, the text isn't going on my build here, but they've been shown to improve not only the lipid profile, but inflammation, endothelial dysfunction, plaque activation. They improve heart rate variability and myocardial performance, as well as provide a certain degree of preconditioning and myocardial protection, all of which potentially have beneficial impact on cardiovascular biology and potential clinical benefits. And this is just a little summary. I won't talk about this in great detail, but there's a lovely, this is from a lovely review article by Darius Mozaffarian and colleagues that has a really great overview of the biology of omega-3 fatty acids in relation to cardiovascular physiology and clinical outcomes. So we think of the epidemiology, and we look at here, this is a cardiovascular health study, sorry, not the cardiovascular, this is a meta-analysis of the cardiovascular health study, looks very similar, the charts. This is actually a more recent meta-analysis of epidemiological studies where the data on cardiovascular outcomes in relation to measured levels of omega-3 fatty acids in the system, and they can be measured directly, but most commonly looking at red blood cell membrane, omega-3 fatty acid levels, which are a very good marker of levels of omega-3s in vascular tissues and myocardium. We can see here that if we track clinical outcomes, and here cardiovascular death and clinical outcomes, we can see that EPA goes down and levels off, DPA progressively goes down, DHA not so much initially, but as the levels get higher, the outcomes get better. Most statistically significant relationship with outcome, the combined EPA and DHA levels. And we can see pretty much across the board, the higher the omega-3 levels, the lower total mortality, lower cardiovascular death, but also interestingly lower cancer death once you've conducted a multivariable adjustment. So these, I think, are very important data, sort of showing a potential epidemiological plausibility between the levels and clinical outcomes. But of course, epidemiology may just be a marker of a healthy behavior or something else that's going on, rather than specifically the causality of the EPA, DHA, and other omega-3s. So if we're thinking of supplementing omega-3s for clinical indications, we'll talk more about clinical indications later. It's obviously important to make sure that we're using pharmaceutical grade agents, and there's the icosapent-ethyl, which is a semi-synthetic, so pharmaceutically manufactured omega-3. But if we're thinking of the sort of the mixed preparations, it's important that we look at how pure these things are. We get everything from sort of fairly unprocessed fish oil to just omega-3 fatty acids with a bunch of impurities. So if we're going to be looking at prescribing omega-3s, we really, in very high risk patients, we need to be using pure pharmaceutical grade substances. And if we think about the manufacturing process for the highly purified pharmaceutical grade omega-3 ethyl esters, they come from fish, from byproducts of catch from largely from South Sea fishing fleets. It's fish body oil. There's an initial stripping where the removal of the sort of the general contaminants of seafood, such as organic agents, pollutants, herbicides, etc., the heavy metals and the organic and metallic compounds, so that we're left with very pure marine triglycerides in a fish oil. But then there's a transesterification where the glycerol component, so there's obviously these are triglycerides, so the glycerol comes off in ethanol under sort of a non oxygen-free environment in a vacuum or nitrogen-rich environment, so you don't get oxidation of the fatty acids, and you get removal of the glycerol, and then the fatty acids are linked to ethanol in an ethyl ester. The non-omega-3 ethyl esters are discarded and used for other purposes, and here we're left for with a pure omega-3 ethyl ester, which at 84% are in the DHA and EPA, and that's highly pure, no organic contaminants and heavy metals, and pretty much all the omega-3 ethyl ester, and then there's a little bit of vitamin E included in that to use as an antioxidant. We know historically that if you use a gram a day in the post-MI setting, you can reduce all-cause mortality, which is driven primarily by a reduction in cardiovascular death, cardiac death, coronary death, and importantly, the biggest relative risk reduction in sudden cardiac death, about a 45% risk reduction, which is accounting for the majority, but not all of the reduction in all-cause mortality. And there hasn't been a trial this large done in the post-MI setting. And I think if we look at post-hoc analysis, it would suggest that the majority of the benefit was derived in the individuals with impaired left ventricular systolic function. So people who've had the greater amount of cardiac damage, and not necessarily the people who would nowadays have been classified as having had a STEMI, the individuals who've had sort of non-STEMI, but the individuals who've had a STEMI or non-STEMI with significant residual left ventricular systolic dysfunction. We wanted to look at this in a real world setting because the GCP study of 1 gram a day randomized trial was done in the 1990s. But we looked in a very large number, so over 11,000 people, of whom 1,500 died in the UK clinical practice research data set. And we found that in the individuals, in a carefully matched post-hoc review of clinical outcomes, we found that there was just under 22% lower mortality in those who were prescribed with a pharmaceutical grade EPA, DHA, ethyl ester within 3 months of their first infarct. And this was actually very consistent with the reduction in all-cause mortality seen in the GCP study. We did some post-hoc sensitivity analyses to show that the magnitude of benefit appeared similar, whether, whatever antiplatelet regime they were on, whatever lipid-lowering intensity treatment they were on, or whether or not they achieved the ESC lipid target. So it seemed to be independent of antiplatelet therapy, statin intensity, or the lipid level. So we believe that there's still good evidence to suggest that a gram a day of EPA DHA in the post-MI setting is associated with a beneficial impact on cardiovascular outcomes. But what about beyond the MI population? So the general prevention population that we're dealing with, the large proportion of patients, and staggering figures presented by Nasreen earlier for the patients in your region, such a high prevalence of this mixed dyslipidemia associated with insulin resistance, high prevalence of type 2 diabetes, and despite good treatment with statin, but perhaps still some scope to intensify treatment, large proportions of patients not adequately controlled, but also with this worrying mixed dyslipidemia profile that even if we get their LDL to target, they're still going to be at risk beyond what we're doing to the levels of cholesterol. So if we think about how omega-3s might help, what these are actually doing in terms of lipid modification, the action really starts at a dose of 2 grams and above, so 2 to 4 grams of the ethyl esters, 4 grams of the semi-synthetic EPA. And what these do, these complex molecules get into the circulation, and they actually interfere with the synthesis of triglycerides by interfering with the diglycerol acyl transferase. They'll slow down the assembly of triglycerides, so they will reduce the rate at which the VLDL triglyceride-rich lipoproteins are produced in the liver. They'll also be associated with increased beta oxidation, so reduction in the synthesis of the triglyceride-rich lipoproteins, thereby reducing the amount of circulating triglyceride. And they also bind to LPL in the peripheral circulation. They actually enhance the catabolism and therefore increase the rate of clearance of these lipoproteins from the system. So there's a double whammy effect. They reduce the synthesis and enhance the clearance of TRLs from the circulation. And if we look at what this does to triglyceride levels, and this is people with mixed dyslipidemia on background statin therapy, they'll reduce triglyceride levels by around 30%, and this is just after an 8-week period of treatment. If we look at total cholesterol levels, this is from the same study, 8 weeks treatment of 4 grams of the ethyl esters, 4.8 reduction in total cholesterol, reduction in ApoB, increase in HDL. Obviously, with that will come a significant decrease in non-HDL, although that's not mentioned here. Statistically significant increase in LDL cholesterol, but actually because the triglycerides are coming down so significantly, this is sort of almost a moot point, the actual increase in LDL cholesterol. What we're really interested in is what's happening to the non-HDL cholesterol and ApoB, which is in the context of the big reduction in VLDL and the reduction in the triglyceride content and the overall biology of the lipoproteins. The actual atherogenicity of the profile is improving with this high dose omega-3 supplementation. If we see in the context of more intensive lipid-lowering therapy, so here atorvastatin 20 milligrams with 4 grams of EPA DHA versus the same dose of atorvastatin or placebo, triglycerides going down, non-HDL cholesterol levels importantly going down, VLDL cholesterol going down, and ApoB going down. So importantly, we're seeing reductions in non-HDL cholesterol levels. So really, we're not in that context where we're seeing big reductions in triglyceride. Changes in LDL are really clinically meaningless. It's actually what's happening to the non-HDL cholesterol, thinking about what's happening to ApoB and triglycerides, and that atherogenicity, the toxicity of the ApoB containing lipoproteins, has improved significantly. If we look at the subgroup analysis of patients with diabetes, even more striking reductions in triglyceride and non-HDL cholesterol, which is extremely important. And if we think back to the actual relative composition, this is a sort of pictorial scheme of what's happening with the lipids, the ApoB containing lipoproteins in patients with high triglyceride and statin therapy. Obviously, you've got a lot of VLDL cholesterol. You know, LDL levels aren't necessarily that bad, but a lot of it's carried in small, dense LDL cholesterol. So actually, with the therapy, although the total cholesterol levels only go down a small amount, what you're seeing is that majority of the shift is in the actual composition of these ApoB containing lipoproteins and shifting the cholesterol more into the sort of larger, more buoyant LDL cholesterol, away from the smaller, denser LDL cholesterol, which is the readout and the ultimate end product of the metabolism of these triglyceride-rich lipoproteins. So the triglycerides are going down, non-HDL cholesterol is going down, and the LDL particles are becoming larger and more buoyant, less small and dense, and less pro-atherogenic. There's also, we see some studies have looked at levels of inflammation and looked at levels of lipoprotein associated PLA2, which also go down, suggesting improvement in the inflammatory status, which is very important as a sort of potential driver of the progression and destabilization of the atherosclerotic plaques. So if we look back historically, there have been a number of studies, and this is before the sort of pharmaceutical grade, the icosapent ethyl and the highly purified ethyl esters. But we just go back, there's researchers in the past have used preparations of EPA and DHA and looked at the impact on cholesterol levels. And we looked at the effect of EPA and DHA on in pooled data. These are data from Way and Jacobson, published some years ago now, showing that if anything, this actually favor, in terms of the triglyceride lowering from the clinical trials, you actually get slightly better triglyceride lowering with DHA than one does with EPA, just in terms of the measured impact on triglycerides. So really what we need to think about the true impact of EPA and DHA on the overall lipoprotein biology, and what's happening at LDL cholesterol in patients with mixed dyslipidemia in combination with statin. Well, actually, if we're focusing just on LDL cholesterol, most of the studies that have looked at the ethyl ester EPA-DHA formulation show that there's a negligible change or actually a reduction in LDL cholesterol. There's only 1 or 2 studies where there was a small increase in LDL cholesterol levels, but that was in the context of a reduction in non-HDL. And if we consider the data in their totality, the combination therapy not only reduces triglycerides, but it reduces non-HDL and ApoB, therefore improving the quality and reducing the atherogenicity of the ApoB containing lipoproteins. So what about on cardiovascular pathophysiology? If we go back to that, here we are, we've got the build here. So antiarrhythmic, preconditioned myocardial function, anti-inflammatory. I've got some data. Here are data from, just as some examples, from the EVAPORATE trial, looking at the semi-synthetic icosapent ethyl EPA at a 4 gram, their licensed dose, in patients with mild to moderate hypertriglyceridemia and average lipid levels. And they've looked at progression of plaque on CT coronary angiography over an 18-month period. And what they showed here is there was a significant progression in the placebo group of the low attenuation, sort of high-risk plaques, particularly the low attenuation, but also the fibrofatty plaques, and a modest reduction in the composition of these plaques, whereas less of a change in the more stable fibrous calcified plaques and less impressive changes in total plaque volume, although all statistically significant. But the big impact of the high-dose EPA is the improvement in the actual characteristics of these lower attenuation fibrofatty, therefore more inflamed, vulnerable plaques. If we look here at the high-dose ethyl ester in the Omega remodel study in patients who had had previous MI and degree of left ventricular dysfunction, we can see that there are improvements in the left ventricular end systolic volume index and improvements in myocardial fibrosis and essentially remodeling of the patients with the high dose EPA post-MI, although of course the current guidelines that you have locally are for 1 gram a day of the EPA DHA ethyl ester, not the 4 gram. But this is showing that there are some potentially beneficial impact on myocardial remodeling following infarct. And just to mention, there were also improvements in biomarkers of inflammation. So clinical outcomes, just to finish off, we know from the GLIS study that 1.8 grams in patients with hypercholesterolemia and stable disease was resulting in better clinical outcomes, and that the outcomes were better in the individuals who had that atherosclerotic dyslipidemia, the low HDL and the high triglycerides at baseline. This was on the background of statin therapy. We know from the Registry study in icosapent ethyl that there was a significant improvement in clinical outcomes combined, primary endpoints, and again, the key secondary endpoint. But again, this is a similar dose used in the Evaporate study, primarily showing improvements in acute coronary syndromes and associated outcomes in these patients at high cardiovascular risk, many of which had stable coronary artery disease, the majority with stable coronary artery disease, and residual hypertriglyceridemia in the background of otherwise optimal statin therapy. There have been no studies of the high dose ethyl ester, EPA DHA formulation hypertriglyceride, although obviously we know that it improves lipid profiles in patients, and also post MI and in the heart failure patients, 1 gram a day will improve clinical outcomes from GCP and GC heart failure. There has been a recent study looking at omega-3 carboxylic acids, the strength study, and this was using the EPA and DHA-free fatty acids, so a different formulation to the icosapent ethyl, the Registry study that I showed you earlier, and different formulation, not an ethyl ester formulation. And this was in patients with significant hypertriglyceridemia in the strength, and that was a neutral study, not worse outcomes, but no benefit in these studies. Currently, it is licensed for use in hypertriglyceridemia, I think in America, but it's not being used that commonly. So at the moment, the current available formulations, the EPA DHA and the EPA ethyl ester. If we look at the most recent meta-analysis, which does include the Registry trial, if you remove the Registry data, the outcomes are really pretty similar in terms of the clinical studies. MI, coronary death, total coronary events, all significantly improved. No difference in strokes, reductions in cardiovascular death, reductions in cardiovascular disease, reductions in major vascular events, but not statistically significant if you exclude Registry. But essentially, I think I have some problems using the meta-analyses because they use different agents, different doses, different clinical conditions. And so I do think we have to be a little bit careful how we extrapolate the data from the meta-analyses. And when I'm thinking of using using omega-3s in my patients, I tend to think about where the data are most suitable from the individual clinical studies for the patient that I have in front of me. Just going back to fibrates, just before I finish up and we move to discussion, we know that if we have patients with the dyslipidemia, that there are significant outcome benefits if we pool the clinical outcome trials. So fibrates, good outcomes in patients, regardless of whether or not they're on background statin treatment, if you have the low HDL and the high triglycerides. But actually, if you've got acceptable levels of HDL and triglycerides, it really doesn't make that much difference to outcomes adding in a fibrate in this meta-analysis. Just a few words on the guidelines. So recent scientific advisory from the AHA, when used to treat hypertriglyceridemia, the EPA, DHA or EPA only appear roughly comparable for triglyceride lowering and do not increase LDL cholesterol as monotherapy or in combination with statin therapy. Sorry. In the DHA containing prescription agents in patients with hypertriglyceridemia, this is just to clarify, sorry. 8 out of the 9 studies, there was no change, and the only one that was marginally increased was the one that I showed you earlier. In that one, there was a reduction in HDL. So similar from the changes in LDL cholesterol reported in Reduce It. And in the patients with very high triglycerides treated with prescription EPA and DHA, there was a similar LDL cholesterol increase, but no increase in ApoB, reflecting increase in the average size of the LDL particle rather than the LDL particle concentration. So don't focus on the LDL in the patients that we're using. Focus on non-HDL cholesterol and triglycerides and think about what these omega-3 supplements are doing to the overall biology rather than just the LDL cholesterol levels. The ESC and EAS recommend treatment with the patients at high risk who are LDL goal with triglycerides greater than 200 with fenofibrate. Don't use gemfibrozil. And then in very high risk patients with elevated triglycerides, we could use omega-3s. They state icosapentaethyl in combination with a statin, but also mention that EPA, DHA can be used at pharmaceutical doses to lower triglycerides, and that the dose of EPA and DHA vary between 2 to 4 grams per day, but 4 grams you get the most clinically effective impact. A few words on the American Association of Clinical Endocrinologists, because I think this is quite a good algorithm in terms of breaking down the levels of risk, high, very high risk, and extreme, and thinking about what LDL cholesterol targets and non-HDL cholesterol targets, triglyceride targets we should be aiming for, and then thinking about what we should be using. And as per all the other guidelines, statin therapy is the mainstay. Intensify statin therapy and to lower non-HDL cholesterol and triglycerides. And this is where we're really focusing on prescription grade omega-3 fatty acid fibrate and or niacin. I think niacin is pretty out of vogue now, but it's there if need be. But actually in these mixed dyslipidemia patients, we need to be concentrating on the addition of a fibrate, really, I think, as first line, unless we're worried about side effects, particularly if we've got CKD or people who've had muscle side effects on high intensity statin. Omega-3 fatty acids potentially a mainstay of therapy here. But if you're primarily just focusing on LDL cholesterol lowering or non-HDL cholesterol lowering, you're not worried about the metabolic dyslipidemia. Once you've intensified the statin, ezetimibe, PCSK9 inhibition, bile acid sequestrants, and of course, potentially down the line bempedoic acid and interfering RNA therapy with inclisiran. Okay, and just lastly to mention Nasreen's guidelines, Nasreen and colleagues' guidelines, that they also mention in the patients with metabolic dyslipidemia, statin therapy, add-on fibrates, and omega-3 PUFAs as well, where appropriate. So I think this is really where we want to be focusing on. And to conclude, I apologise for overrunning by a few minutes. Hopefully you've been able to bear with me and that you found my talk interesting. But I think to summarise, I think we need to think about reducing residual cardiovascular risk in these patients whose non-HDL cholesterol is not at target. So obviously we focus on non-HDL cholesterol levels in these individuals as the mainstay. Statins plus or minus PCSK9, ezetimibe, PCSK9, where the non-HDL cholesterol levels are very high. But in the individuals where you have that metabolic syndrome, low HDL, high triglycerides, fibrate would be, the guidelines would suggest that that's the next line therapy. And then we would add in the high dose omega-3 PUFA, clinical grade, pharmaceutical grade supplementation to manage residual hypertriglyceridemia as an add-on or as an alternative to a fibrate where you're concerned about the potential for combining a fibrate and a statin. And of course, and I haven't talked about this at all, but obviously antiplatelet therapy in patients with atherosclerotic disease, manage the blood pressure, use beta blockers, ACE inhibitors, ARBs, other heart failure therapy, manage the diabetes. And if you've got patients with CVD, think about GLP-1s, SGLT2s, patients with heart failure, it's not contraindicated, Entresto, device therapy, dapagliflozin, perhaps empagliflozin when it gets its license. So think about managing global cardiovascular risk, but here with regard to lipids, primary focus non-HDL cholesterol with statin plus or minus ezetimibe, PCSK9 therapy, but with the residual metabolic syndrome, residual lipid risk, fibrates and high dose omega-3s. So thank you very much for your attention, and I'm sure there'll be some questions because they were already coming in during Nasreen's talk, I look forward to our discussion. Thank you very much.
Thank you very much, Julian, for this excellent and informative presentation and talk. I'm sure the audience learned a lot. Just to let you know, we are over 1,000 participants.
Wow.
So, and I'm really glad to see very sort of informative and interactive participation. We have many interesting questions. So we have we run a little bit over time. That's fine. We can compensate. We have like 15 minutes for discussion. So to start with, a question here, I think we can, both of us can give our input in certain questions. So a question here says, in diabetic patient with poor glycemic control and elevated LDL cholesterol, should we achieve the glycemic control first and recheck the LDL later, or start a statin immediately? Well, as endocrinologists, seeing a new onset type diabetes, you know, at the first session, you would be focusing on diabetes, and you don't want to really distract the patient with, you know, several sort of addition of medications. So the primary focus is on diabetes management. And along with that, you're going to talk about lifestyle changes. So diet and exercise and so on. So you're hoping that during the follow-up visit, you might be seeing some changes in glycemic control once you started the treatment, and as well as you're gonna definitely address the lipid disorder if there is any during subsequent visit. Now remember, the guidelines now are very strict, and the threshold at which we should really start and consider lipid-lowering therapy in diabetic patients is actually LDL cholesterol of 70 milligrams per deciliter. And the recommendation is from age, different societies recommended different age cutoffs, but 40 years, like according to the ADA, is your cutoff to start statin therapy. And it's very difficult really to achieve an LDL goal below 70 milligrams per deciliter in a diabetic just with, you know, diet control and glycemic control. Most of these patients will require, you know, statin therapy as an add-on to their anti-diabetic regimen. So any more you want to add on that, Julian?
Well, no, that's a great summary, and obviously you're better placed to answer that question. The one thing I would add is that obviously with the initial targeting of the diabetic glucose management and addressing all of the key issues, you should see an improvement in the lipid profile with the lifestyle approaches that one would hope this patient would initiate. But I just think from a general perspective, it's important not to hang around too long before you initiate the lipid lowering therapy if it becomes appropriate. As you say, it's going to be appropriate in the majority of patients. But I find when you're managing these patients, and obviously I'm coming from the cardiologist's point of view and preventive cardiologists, if you're starting too many medicines and focusing on too many things at the same time, there's always the problem of, if someone gets side effects, which as we know are quite common, and these patients get symptoms that are independent of the medicine you treat, that you don't know where you are. So focusing on one thing at a time is very important. But it's really important, I think, to see these people as frequently as it's feasible and realistic in terms of the constraints of your practice, so that, you know, it's not sort of 6 months to a year before you think about starting statin therapy. You know, I think time is of the essence, because often these people who present this, the majority with type 2 diabetes, they've been incubating this metabolic risk for many years, and they may already have, you know, overt clinical coronary disease, or certainly important subclinical disease, but they're very sedentary, so they're not presenting with their angina. If you put them on the treadmill, they get chest pain and ECG changes, or do a more sophisticated test. You know, I think, you know, time is of the essence really, but I agree, focus on the diabetes first and then address the lipids.
Very good. Very good. This is just a comment from our dear colleague cardiologist, Dr. Fahad Al-Nouri from Saudi Arabia. As a comment on Lp(a), that race is a key variable in assigning Lp(a) cutoff values for coronary heart disease risk assessment. Therefore, further research is necessary to develop the most clinically useful Lp(a) cutoff values in individual races and ethnicities, and definitely we agree with that. Yeah,
definitely. If I could add at the moment, because there's a lot of interest coming in Lp(a), because I think there was a period, many years ago where the epidemiology looked good. Then there were a few studies where there was a less strong association, but more recently with the genetic Mendelian randomization data and more comprehensive epidemiological outcome studies, we can see that there are variations in the race because it's so genetically driven. But we need to see whether there's different cutoffs that link to risk with different ethnicities that I think is important. And at the moment we're using, well, not everyone's using it, but in the areas, sort of more sophisticated prevention centres, we're actually measuring LPA more frequently. At the moment, there's nothing we can really do about it that we know, but we should use it if they're above the levels of risk specified in the guidelines. We use 50, I forget the units to be honest. And
50 milligrams,
50 milligrams,
50 milligrams per deciliter.
Some it's 500 if you use it, sort of an order of magnitude different. But yeah, it's important as a marker of risk. So if you have elevated levels, then we would perhaps push people up into a high risk category. So consider higher, more intensive targets for lipid management and so forth. But I guess you guys may well be participating in this. We're just recruiting patients into the Horizon study, which basically it's the first agent's been clinically shown to reduce levels of Lp(a). So we're taking patients, it's essentially secondary prevention population, optimal lipid lowering treatment who have high levels of LPA, to see if we can improve outcomes by specifically targeting, switching off the gene that produces LPA. So it's going to be a really exciting area and should hopefully come into the mainstream in the next few years.
That would be very interesting to see. Another question is, do you ever advise patient to take statin every other day or once a week if LDL is low? Go ahead.
Yeah, well, I mean, it depends on the patient. So if a patient's at increased cardiovascular risk and secondary prevention or high risk primary prevention patient, then we should really be using LDL lowering, statin therapy, regardless of the absolute cholesterol levels. Often patients get side effects even on relatively low dose of statin therapy. These patients who have side effects of multiple statins, I would often try very low dose rosuvastatin, 5 milligrams. I'd even start off at once a week. And then if they tolerate that, I'd move to alternate days, Monday, Wednesday, Friday, see how they get on with that, and titrate up until they reach the threshold. Sometimes they even get symptoms at once a week. So with me, I'm managing patients, I'm selecting them for statin therapy. Obviously, if they have very high levels of LDL cholesterol, but then considering their global cardiovascular risk as secondary prevention or high risk primary prevention patients, and managing them with a statin regardless of that starting LDL cholesterol levels. So if they're intolerant, they have low levels, if they can tolerate weekly or alternate day doses, I still think they're likely to be better off.
Yeah.
Would that agree with your practice?
Yes, absolutely. I agree, and that would be very efficient in statin intolerant patient. A common mistake probably some physicians would do that when they see patients with very low LDL levels, let's say an LDL level of 1.4 millimoles in actually a very high risk patient, or 1.1. I notice when I see the patients referred to me that physicians panic and would lower the statin dose. So that's a very important message over here, that we want these patients to be as low as possible LDL. There were no safety signals in the clinical trials that were conducted, like in the PCSK9 trials, the Improved ezetimibe trial. We went really low, and there were no concerns of any safety concerns with achieving very low LDL levels. So please, in these patients who are tolerating their statin, they're doing really well. You don't have to lower the statin dose because the LDL cholesterol is very low in these high-risk patients.
Absolutely. I think they saw that the outcomes were good, and that there were no safety signals down to LDLs of 0.2 millimoles per liter, which is
absolutely,
it's like down to about 20.
Yep, 20 milligrams per deciliter. Absolutely, absolutely. Another question is here: at what age statin and fibrates can be started in familial hypercholesterolemia? Some have high readings in 20s and 30s of age. Yeah, now in FH patients, like I mentioned, this is a genetic disorder, so you need to really pick these patients and detect them and identify them as soon as possible. And if you detect one patient with FH, you need to do a cascade screening the family members. And even I ask my patients to screen their children as well. So it depends really on the presentation. Severe forms of FH, like homozygous or compound heterozygous FH, can be detected as early as childhood. And the currently FDA approved statin therapies for children. You can start as early as age 8 or 10. Atorva is being approved and used in children and kids, and Rasuva with very high, pravastatin and with very high cholesterol levels. So yes, I mean, if they fit the criteria based on the Dutch Lipid Clinic Network criteria or the Simon Broom or the WHO, you have 3 tools to identify these patients, then they should be treated as early as possible. We should not wait until they reach their 20s or 30s or 40s and present with an event. Fibrates in FH is actually not commonly used, mostly high-intensity statin, ezetimibe, PCSK9 inhibitors, and LDL apheresis. There are some patients where when you have limited options for lipid-lowering therapies, fibrates have been used in these patients, but primarily very high levels or homozygous FH are treated with LDL apheresis. And we do have LDL apheresis centers in the region here. Saudi Arabia, you have certain centers doing that. In Oman, they're doing LDL apheresis for these patients.
Yeah, I mean, I think with the fibrate, it would be in terms of the familial dyslipidemias, we'd use it more in the familial combined patients where there's that they have high levels of triglycerides, often with low HDL.
Yes.
And again, it's down to the absolute risk in the family history, although you'd be less likely to be treating children with FCH, I believe. I don't look after children, but
right.
Yeah.
So another question is, in practice, we find that high triglycerides, more than 900, gemfibrozil only is the most efficacious to reduce the triglyceride, more than fibric acid or omega-3, 4,000 milligram, which increases the multiple pill burden. How would you comment on that?
Well, I don't know. I don't look after a lot of people with the extreme hypertriglyceridemia in my practice. They tend to be seen by chemical pathologists and the metabolic physicians. So I mean, I don't use gemfibrozil in my practice, so I defer to the experts. But I think in people with that extreme hypertriglyceridemia, you're almost certainly going to end up. It's important to find the underlying cause. So there's usually an underlying cause for these patients, be it genetic or often just gross obesity, type 2 diabetes, and calorie excess, maybe with a bit of alcohol thrown in. But I mean, I think you're going to be combining omega-3s and fibrates, and I defer to your expertise, Nasreen, in terms of gemfibrozil versus other fibrates. But I only really use fenofibrate in my practice because most of my patients are on statins, and the outcomes are so good with fenofibrate.
Yeah, actually, definitely, I agree with you. Triglyceride levels at this level and very high, most of the time you will need multiple agents to control the triglyceride level. These are usually patients with combined familial dyslipidemias, chylomicronemias. So definitely one agent would not really be effective. I don't see personally in clinical practice differences between the effect of gemfibrozil versus fenofibrates. I tend to be relaxed more with fenofibrates because in these patients, sometimes you do want to use, high dose omega-3 along with statins. Now, for the audience, remember that statins and high intensity, moderate and high intensity statins can lower your triglyceride level in the range between 30 to 50%. So there are some effects with statins as well. So you would be sort of more comfortable in combining these agents together in these severely elevated levels of triglyceride. Another question here says, can fibrates be added to statin despite normal triglycerides?
They can, but I'm not sure why you would want to. I mean, I think the main indication for fibrates, the evolution with the data, is not just to raise HDL cholesterol, though it will. I mean, if you want to use it in addition to ezetimibe or PCSK9 therapy on top of statin therapy in patients with extreme dyslipidemia, or for whatever reason they haven't tolerated that. So I wouldn't generally use it. It can be, but it would be to reduce total cholesterol. But there are other agents that you might select beforehand in the algorithm, but you can still add it on or use it as an alternative if patients don't get on with ezetimibe, or they're not quite bad enough to justify the additional expense and perhaps inconvenience of injections with the PCSK9 therapy. So they're still good at lowering LDL cholesterol, but it's maybe not the one you would choose first. So I generally use it for the patients with the mixed dyslipidemia in addition to statin therapy, when you're approaching LDL control.
Yeah, totally agree. If the lipid profile is still high, which is better, increasing statin dose or adding another agent like ezetimibe or fibrate? So someone who's uncontrolled,
Yeah, I mean, it depends which elements of the lipid profile. I mean, if your problem is primarily, patients don't have that elevated trigs, plus or minus low HDL, and you're just focusing on the non-HDL cholesterol, the evidence is really best with intensifying the statin therapy, because we know that you get better outcomes intensifying the statin therapy versus lower intensity statin therapy from the clinical trials like the Prove It and so forth. So I would always get them onto the highest tolerated dose of the statin, and then see where we are with the non-HDL cholesterol. And if you're relatively close to target, then add ezetimibe. If you're still away from target, then add in PCSK9, unless, of course, you've got this residual mixed dyslipidemia, in which case I would favour fenofibrate plus or minus omega-3s as the next add-on therapy.
Yeah, very good. So, and that's very important. It really depends your baseline LDL or non-HDL that you're looking at.
Yeah.
And what is your target that you're looking at to achieve? Again, we recommend if you are looking at more than 50% reduction, then definitely if the patient can tolerate high intensity statin, you would do that. If not, then remember intensifying statin dose would give you additional 6% lowering, while adding ezetimibe would give you additional 25 to 27% lowering in LDL cholesterol. And of course, there is a big additional benefit, about 50-60%, when you add PCSK9 inhibitor to statins. Now, at which patient we should start fenofibrate from the start before statin?
I think really, I mean, in my practice, I'm seeing patients with cardiovascular disease or high risk primary prevention. I think the patients that you would consider fenofibrate initially are the people who are presenting with primary triglyceride issues, where there's the pancreatitis risk. I mean, that's more your area, and I defer to your expertise. But you asked me, it seemed like you were asking me the question. I'm like being tested on my general medical knowledge, but it's kind of outside my remit. But I think, that from my expertise, I'm not primarily seeing those
Yeah.
patients as a first line. Those patients would generally be diverted to, you know,
Yeah.
people who have your scope of practice, or my clinical biochemistry colleagues.
Yeah, that's absolutely correct. So primarily when you have primarily high triglyceride levels, so when your triglyceride is above 500 milligrams per deciliter, your primary focus should be, according to the guidelines, on triglyceride. You tend to initially ignore what's going on at the LDL, non-HDL. You focus that and you want to prevent pancreatitis. So you put these patients on a very low-fat diet. So dietary intervention is very important, and it's really a great step in improving triglyceride levels. You may want to consider adding, yes, at very, very high levels, starting with fenofibrates, and then later on you can address, you know, the LDL and the non-HDL. And again, if you want to add later on statin along with fenofibrate, it's fine, because it has 30 to 50% reduction in triglyceride levels as well. We have another question here on the HDL. I've seen a lot of questions coming on HDL cholesterol. So the question here is that it says, does very high HDL that is above normal level has any clinical significance? Well, the HDL is now quite confusing. It used to be sort of a straightforward sort of lipoprotein. We were looking in the past, like from different clinical trials, like the Framingham Heart study, that there is an inverse relationship between the HDL cholesterol and adverse cardiovascular outcome. But when we started developing these agents like the CATP inhibitors to improve the HDL cholesterol and increase the HDL cholesterol, unfortunately, these trials were terminated and we couldn't really achieve the aim of these studies. And we have seen some adverse events with that. And that brought us to what sort of, we have sort of a U-shaped sort of relation or you know, association of the HDL cholesterol and adverse cardiovascular outcome. So this U-shaped association is that at some levels of very high HDL, it was noticed, for example, from the NISA study, another Copenhagen study, that levels above like 2.5 or in males or 3.5 in females, there were associated adverse cardiovascular outcome, while very low levels like below 0.78 millimoles is also associated with adverse outcome. So we are in that gray area with the HDL, and we're trying to understand this U-shaped sort of relationship with the HDL level and cardiovascular outcome. Okay, so this is for the HDL. I think we have 1 minute to go. Let me pick which question. Is ezetimibe a choice or PCSK9 inhibitors for cases? This is a very long case. They're talking about reduce it trial. Yeah, in general, there are several questions about the omega-3. Which omega-3 would be your preference?
Yeah, so in the UK, we're just using the highly purified ethyl ester, the EPA DHA combination therapy. That's the one we have available at present. So that's the one we use in. I'm using that in my clinical practice. Obviously, you have the semi-synthetic EPA now with the data from the Reduce It trial. I think in terms of the impact on triglyceride levels, that we're seeing similar effects on triglycerides in relation to the use of the two agents. So I think potentially the effects are likely to be interchangeable in terms of their impact, but the clinical outcome trial data in the patients predominantly with stable coronary artery diseases with the icosapent ethyl, but in terms of the biology and the the dose effect, and we don't have comparative clinical outcome data from the two trials. So I suspect that we'd see a similar impact on clinical outcomes, and I'm quite comfortable using the ethyl ester formulation in my practice.
Very good. Excellent. It was a great pleasure to have you with us tonight, Professor Halcox, and we really enjoyed your informative and excellent talk. And I hope I delivered as well important epidemiological data in the region to our colleagues to see how serious is the lipid disorders in the region. We would like to thank you all for attending this webinar and for your participation and interaction. I would just like to remind you that this webinar is being recorded and it is going to be accredited by the Dubai Health Authority. So there you will be receiving CME accreditation for this activity, and it will be emailed to you by our organizer Amber via your emails. And also we appreciate if you can take time to complete a feedback on this activity that will be displayed on your screen when you log out from the webinar. I have seen several questions under the Q&A box asking about the Gulf Association, and because I mentioned that some of the regional guidelines are posted. So we are the Gulf Association of Endocrinology and Diabetes. This is our website, www.gaed.info, and you can become a member in this association. The membership is open and free until if you register actually before January 2022, you can have a 1-year free membership. So the free membership entitles you to access all the webinars for free, including tonight's webinar is going to be posted on the website, and you can access the different congresses arranged by the Gulf Association of Endocrinology. This webinar will also be posted on the website. And with that, I would like to thank again Professor Halcox for joining us tonight. I would like to thank Abbott for sponsoring and organizing this event. Abbott always brings us with really high quality, high caliber speakers with us. Always a pleasure to work with you. I would like to thank our event organizer, Amber, for organizing this webinar tonight. And with that, I would like to conclude the webinar and wish you a lovely night, and good night, everyone. Thank you.
Thank you. Thank you.
Thank you.
Good night.